So Commander HF was a large-scale clinical trial involving about 5,000 people worldwide. And it looked at a very interesting question, and that was whether or not low-dose rivaroxaban, 2.5 milligrams twice daily, would improve outcomes in patients with chronic heart failure and recent worsening. The population all had coronary disease, so they had underlying atherosclerotic disease, and they were in sinus rhythm. And the results, quite honestly, were disappointing. They showed no significant impact of rivaroxaban on a composite outcome of mortality, stroke, and MI. But it was interesting, and that's what really led to the analysis that I presented here at the AHA. When you look at the driver of that composite endpoint, it was predominantly mortality. And that was an important insight because it showed us that giving a thrombin activator inhibitor does not influence events in a heart failure population that has a recent episode of worsening. What happens there is that outcomes are driven by the pump failure, and a thrombin mechanism is probably not involved. However, when you look at the other endpoints, the MI and stroke, there appeared to be a signal that rivaroxaban was having a favorable effect. So we decided to go back and look at a thrombotic endpoint, which was comprised of MI, stroke, sudden or unwitnessed death, pulmonary embolus, and deep venous thrombosis. And we used the commander population. And when we did that, we showed that there was an overall 17% risk reduction. This was significant in favor of rivaroxaban in the clinical trial. What was interesting was that when we then looked back at the other studies that had been done using low-dose rivaroxaban, the Atlas ACS TIMI 51 study in patients with acute coronary syndrome, and the COMPASS study in patients with stable atherosclerotic disease. Each of those studies had heart failure patients in the study. Each of those studies showed a favorable effect of rivaroxaban. When we looked at Commander, our study, in that context, we realized that mortality, which was due to pump failure, was driving the primary endpoint. But when you look back at those thromboembolic events, it was very similar to what was being seen in COMPASS and in the Atlas studies, suggesting that there's background thrombotic events going on in this heart failure population, and that rivaroxaban favorably affects the risk for those events. Well, remember, this was a sub-analysis, and it's more hypothesis generating, but I really like to look at this data in the context of the other clinical trials and look at thrombotic events in Commander HF in the context of what went on in COMPASS and in the Atlas study. And in all of those studies, again, we see this background, if you will, of thrombotic events and a favorable effect of rivaroxaban. Now that low-dose rivaroxaban has been approved, at least in the United States just recently, for the management of people with stable atherosclerotic disease, what this data would tell us is that whether or not there's heart failure present, you're still likely to have a favorable effect. However, the data from Commander also shows us when there's an episode of worsening, a hospitalization for acute heart failure, adding the drug is not going to affect the long-term outcomes in this population. Yeah, I hope that it does. There are two areas that I think would be very interesting to go further into. One is to do a study in the heart failure with reduced ejection fraction and see whether or not you can prospectively reduce the risk of these thromboembolic events. Because we've done it now in a post hoc analysis, and the data that I alluded to before from COMPASS and ATLAS also were post hoc analyses. I'd like to see this being done prospectively. And then finally, the very intriguing possibility that this may have an effect on outcomes in the heart failure with preserved ejection fraction population. That's a study that also I think really needs to be done.